With that, Melora, I'll pass it off to you.
Thanks so much, Marie. And it's great to be here virtually with everybody. Just a little bit about the California Healthcare Foundation, for those of you who don't know us, although I imagine many do. We're an independent nonprofit foundation that works to improve healthcare for all Californians. And we're especially focused on the Californians with low incomes and others that are not served well by the current system. So because of that, we have a strong interest in CalAIM and think that it represents an unprecedented opportunity to ensure that Medi-Cal works for everyone, and particularly to improve care for people with complex needs. In today's presentation, I'm not going to talk about all of CalAIM, but I'm really going to focus in on the aspects that are about integrating social needs with care. Before I jump into the nitty-gritty of CalAIM, I thought it was helpful to start with a story. And this story comes from an experience I had as part of the Whole Person Care program when I worked at Health Plan of San Mateo, because CalAIM really builds on whole person care. And one of the first people we helped was an older gentleman, I'll call him John, who'd been living on the streets for decades. He had developed a case of body lice and sought help from our street medicine team. And in the past, he'd been approached multiple times with offers of shelter, but was not interested. But over several months, through the treatment of his lice, he developed a trusting relationship and was willing to accept help with other concerns. His situation was really complicated. He had advanced cancer, he was estranged from his family, and unfortunately, his life on the streets had given him a long history of involvement with the criminal justice system, including a public indecency charge that had landed him on the sex offender registry. Many of us thought that it was going to be impossible to get him housing, but it took a team and Herculean effort, and we got him housed. And when he sadly died several months later, he did so in his own home, with his now reconciled family around him and a palliative care team engaged to keep him comfortable to the very end. But what did it take to get there? It started with a table in San Mateo almost exactly 5 years ago that, by the way, looked nothing like the picture on your screen. It was crowded. It was in a basement conference room with no windows. But around the table were service leaders from primary care, from mental health, from street medicine, from the substance use system, from the older adult agency, from housing authority, and me from the health plan. And we learned together through clients like John. None of us could have helped him alone. And in order to help him, we all had to understand a little bit more about how each other's parts of the system worked, the barriers and constraints we faced, as well as the successes we celebrated. Together, we figured out where there were gaps that we could fill and services and supports that were missing in the system. We learned what coordination could only happen in real time around the table and what could happen asynchronously through data sharing. Most importantly, we learned to trust each other and to hold each other and our contracted partners accountable. Through people like John, we learned how we needed to change the system. And across the state, there were many such tables. And at its heart, CalAIM is about taking this powerful teamwork that has already begun in counties and clinics and plans and spreading it across the state in an equitable way, so that no matter where somebody lives and no matter where or how they seek support, all people with Medi-Cal coverage can get what they need in an integrated way. It's really about coupling clinical care with non-clinical services in more flexible ways. And it's about systemic equity, changing the frame so that the onus is on the system to proactively identify gaps and disparities, rather than just responding to whoever comes in the door or knocks the loudest. But let's get concrete. CalAIM is big, it's multi-year. What could it actually change, and how does it impact your work to integrate and address social needs? So I'll start by talking about the changes that are coming in 2022 and 2023. CalAIM, again, is a 5-year program, but wanted to really focus in on these kind of first 2 years. In 2022, we have 3 programs: enhanced care management, community supports, and providing access to transforming health, or PATH. And in 2023, building on that, we have population health management, some important changes for seniors and people with disability, and coverage and supports for people transitioning from incarceration. If we start in 2022, there are two important interlocking programs. Enhanced care management, you can think of that as kind of a care concierge who can help patients navigate the fragmented patchwork that is our Medi-Cal system. And then community supports, which helps patients access the services they need to fill in the gaps in our systems that aren't part of traditional benefits or our traditional silos. And PATH provides the resources to build the infrastructure to increase that capacity and increase integration and data sharing to make those programs successful. So let's dig into enhanced care management. This is a required statewide benefit that will be administered through managed care. It's part of a broader population health strategy that will largely be implemented in 2023, with ECM at the very top of the pyramid, caring for about the 1% that have the highest level of needs and need the highest intensity of care coordination. It's high touch, it's in person, it's through community-based providers at the point of care. It's whole person. So it includes services that are outside of managed care, like oral health, substance use, mental health, aging and adult services. And it goes all the way from outreach and engagement through to care planning, through transitions between settings and closed loop referral. It also engages the family. In 2022, there are 3 populations of focus that are being rolled out for enhanced care management. And that's people experiencing homelessness, people who end up using a lot of acute services, and adults with who interact with the especially mental health system or the SUD system. You don't need to take notes. I know I just went through a lot of this. We'll share this all in detail, but just wanted to give an overview of ECM. Community supports, or in lieu of services, are really designed to support people in the community instead of in institutions like hospitals, nursing homes, and jails. They are an option for plans, and there are 14 individual services, but they really fall into 3 categories. Housing supports, short-term recovery or respite supports, and then supports to help people live independently in the community as they age. We have a sneak preview of what plans are going to be offering in the beginning of 2022 that DHCS just published last week. We expect this map to change over time as plans can add services every 6 months, and some counties are staged later in the rollout. But the key takeaways we see is that much of the state will have access to some community supports right away, and many of the large population centers will have access to a pretty broad range of services. There is significant variation. Some plans are offering all services in January, and others are offering none. But this is reflective of the state's approach and timeline for rollout of the services. The services are voluntary for plans, and the counties that did not participate in whole person care or health homes, they actually don't go live with enhanced care management until July. So they'll have an opportunity to adjust their community support offerings between now and then. If you look at the right-hand side by service, by July of next year, more than half of the planned county pairs will be offering meals, housing services and supports, asthma remediation, and home modifications for accessibility. Medical respite or recuperative care, which provides a safe and stable place for recovery and healing for people experiencing homelessness, is just behind that. And then sobering centers, which offer a short-term alternative to jail or the hospital, will be offered in about 1 in 4 planned county pairs. The remainder of the services, many of which relate to aging in place, are being offered less commonly, likely because the corresponding enhanced care management population doesn't go live until 2023. And that's also when plans will assume greater risk for institutional long-term care, which those services are a replacement for. So PATH is an important source of revenue to help us get there and to help things be successfully implemented, specifically ECM and community supports. It's also designed to support the CalAIM initiatives for people who are transitioning from incarceration. So DHCS has sought about $1.8 billion from CMS to invest in one-time infrastructure, investments around data exchange, workforce development, and capacity building. PATH is also really intended to be an important tool for equity. Resources will be targeted to providers and CBOs in communities that have historically been under-resourced. So that's 2022 in a nutshell. In 2023, we layer on some additional reforms. So population health management, the strategy that's looking at everybody, the full pyramid, administered by plans. The carve-in of long-term care, which means that plans will be taking more risk for institutional long-term care. And there'll be some additional alignment and integration for people who are dually eligible for Medicare and Medi-Cal. Pre-release coverage and reentry supports for people transitioning from incarceration, and then enhanced care management for some of these new populations. Plans will also have the opportunity to add additional community supports. This is very much a work in progress. The changes are starting to take place in January, but the waiver is still being negotiated. So there's dynamism and uncertainty. We think that's a really small price to pay for the opportunity to sustainably spread and scale what we know works from whole person care. But it is where we are. In order to pull this off, we really need to work together and support one another. Together, we can build something that achieves these important goals of integrated whole person care delivered equitably. But we learned through John that we can't do it if we just try to work alone. So I wanted to turn it over to some of our CIN partner plans. They're tasked with some of the first aspects of implementation of these changes. So we thought it would be really helpful to the network to hear their perspectives and where they are as we head into 2022.
Thank you so much, Melora.